Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show. Today, bringing you another really awesome guest involved in creating a better and safer tomorrow for all of us. Today, we have the honor of being joined by Dr. Naheed Bhadelia, who is a board-certified infectious disease physician, the founding director of Boston University Center for Emerging Infectious Diseases, as well as associate professor at the BU School of Medicine. She's served the senior policy advisor for the global COVID-19 response for the White House COVID-19 response team. They're coordinating the interagency programs for COVID, vaccine donations in the U.S. Was also policy lead for something known as Project NextGen, which is a $5 billion HHS program aimed at developing next generations in vaccines, treatments as well for pandemic-prone coronaviruses. She also serves as the interim testing coordinator for the White House Mpox response team, as well as she serves as director and co-founder of the Biothreats Emergence Analysis and Communications Network, also known as Beacon, really interesting open source outbreak surveillance program. Between 2011 and 2021, Dr. Bhadelia helped develop and ultimately serve as the medical director of the Special Pathogens Unit at the Boston Medical Center, really interesting medical unit designed for care for patients with highly communicable diseases, as well as a state-designated Ebola Treatment Center. She also previously was associate director of BU's Maximum Containment Research Program, known as the NEEDLE, or the National Emerging Infectious Disease Laboratories. Her current work focuses on operationally global health security, pandemic preparedness, as well as medical countermeasure evaluation, clinical care for emerging infections, diagnostics evaluation, as well as infection control policy and healthcare worker training. And she has extensive experience, as we'll get into, on everything from H1N1, Zika, Lassa, Marburg, on to Ebola and COVID. Her bio is a lot longer than what I'm going to be going into today. We're going to be putting it obviously in the show notes, but honored to have her with us. A lot to get into today. Dr. Naheed Bhadelia, thank you so much for taking the time to come on the show.
Thanks for having me.
Great having you. Lots of really interesting stuff to get into today. Love to start off at the very beginning. In reading about you, I enjoyed sort of taking a little international journey, which I think started in India, heads to Sweden, then Saudi Arabia, then ultimately lands you at Tufts, where you focus on medicine and infectious disease. And really interestingly, as you're doing your medical degree, start working as an HIV counselor and clinic coordinator for this student-run clinic in Massachusetts. Take us back a bit. Tell us a little bit of the early story here, because I think it sets the stage for everything that you ultimately do.
People always ask me what my parents, so we actually moved to the US when I was 12 or 13. Grew up in Brookline, Massachusetts, which everybody I talk to says they know somebody from Brookline High. It's a big school. So I grew up, as you said, I was born in India, and we left India when I was 4. So the pathway is there to Middle East and then to Sweden. And it's interesting, and many folks, doctors, engineers, others in my parents' generation, the brain drain generation, if you will, there is this like slow westward motion from India to somewhere. So you'll find a lot of kids my age, probably in like mid to late 40s, who had parents and childhoods where they spent a little bit of time somewhere in the Middle East and then somewhere in Europe, and then ended up here as either early secondary school or in high school. Yeah, a Bostonian for all purposes, from then onwards, and I did my undergraduate, master's, and medical school at Tufts. And I was there so long that the dean of the medical school said if I stayed for residency, they would name a chair after me. And I would joke that I'd already paid them enough money. They should name a chair after me anyway. But that's sort of the pathway. In between, there's after I finished my undergrad degree, I was recently reflecting on this with someone. I did a year of work with Oxfam America, which focused on they had received a $3 million grant from Bill and Melinda Gates to work on civic engagement among American youth. And my work had been to help craft a program that does civic engagement around global issues, global economic development issues, which is partly what Oxfam focused on. And it was as a first job, it was so eye-opening because it was learning about the issues, but then also learning about how you make a compelling argument about the greater common good. I really had some wonderful mentors during that position. And then when I started medical school, the Fletcher program I did between my third and fourth year, and then continued doing, I think you mentioned my thesis or something at some point. So I did that during my fourth year of medical school in between rotations, trying to get that master's thesis done before graduation. So I graduated in 2005 with both the focus on what would be, global health security, security studies, as well as more medicine and infectious diseases.
Right. Yes, let's talk for that for a couple of minutes, because as you mentioned, you were also at the Fletcher School at Tufts. Your thesis was entitled "Modeling and Employing the Human Security Approach: A Health Security Perspective on the Current International Response to HIV Epidemic." And it's interesting because the other person that came on the show that talked about that specifically was Ambassador Nkengasong of the PEPFAR program, and this important connection between health security, human security, national security. And I really enjoyed the fact that sort of seeped into your work quite early on. I wonder if you could just say a couple words about your thesis from that perspective.
Yeah, I would suggest nobody read it because it was a master's thesis and I was very young. I wrote it in like 2004, probably. So we're like, it's 2003, I can't remember. So over 20 years ago at this point. But I think the gist of it is well, we know so well and seem to keep forgetting every once in a while, which is that infectious diseases clearly have a role to play in assessing our national security. But beyond that, human security, which many folks may not be familiar with that term. With national security is security at the borders, human security is really security at the individual or the community level. And I think the work that I'd been doing at Fletcher, and of course, bringing in the work and experience that I'd had with Oxfam, actually, right before I started at Oxfam, I had been, small world, Vivek Murthy, who's now the Surgeon General, ran a program called Visions Worldwide. And so I'd volunteered with his program in India as a HIV educator. In a bunch of lower socioeconomic status sort of communities who didn't have as much access outside of Delhi to some of the health information. And it really brought together some of the work around Oxfam and that experience, which was at that point, if you harken back to late 90s and early 2000s, HIV epidemic was just turning into the AIDS epidemic. We still didn't have extensive access to, PEPFAR was gearing up. We didn't have as extensive access to ARVs around the world. And what you were seeing was just decimation of communities, particularly of individuals within the age group, which is, generally infectious diseases tend to affect the youngest or the oldest, right? This was affecting teachers, soldiers, physicians, and many of the countries in the sub-Saharan African area, which is probably why this is so close to John's heart as well. Those that were more than 20% had more than 20% prevalence. Like you really saw a complete upheaval of the social order in terms of how you're going to try to provide for all those essential services and maintain a social cohesion while you have an infectious diseases that's taking that toll. I think we forget, and it's so important. I'm actually really glad you brought that up today, Ira, because PEPFAR is back on the chopping block
Right.
potentially, and there's this question of whether um, it helps or not. It is a incredible example of bipartisan commitment to something that made it really changed the world. We don't think about the fact that it helped avert this very thing that I'm describing in all these countries where there was over 20% surveillance. You now go to places like Uganda. I mean, Uganda, which I did end up working on many years later, I know it's actually pretty well set up in terms of its health systems, and they've learned all those lessons out of that pretty high HIV prevalence period that they went through. PEPFAR also has made an incredible contribution in helping set up potential primary care access to HIV positive patients, right? And then during the COVID-19 pandemic, in many cases it was like a swing resource that could be used to get HIV, COVID testing or COVID treatment out, particularly to vulnerable populations. So I would hate to see that of all the programs to go, particularly just given, as you talked about, some of the work that I've done in the past on that. Not on
Absolutely.
PEPFAR, but studying the topic.
No, it's the well, it's not saying it's the one example, but it's an example of where I'll just I know overuse this term, sort of moonshot thinking
Yeah.
and planning really impacts the world, and with taking a death sentence 20 years prior to a very manageable, curable state. So yeah, no, I'm completely with you on that front. Um, Before we get in, and I mean, we're going to take some, aside from your work, in Boston, and then, some of the places that you go sort of on the journey in terms of Liberia and Sierra Leone and DRC. I was wondering if you could spend also a couple minutes talking about some of your experiences, at Boston Medical Center, at BU, setting up the Special Pathogens Unit, because here, you're dealing with the nasty of the nasty stuff, and also creating this biosafety level 4 laboratory. We a couple of months ago we profiled Dr. Jacobs Young from USDA, and she was talking about the MBAF and some of what
Yeah.
went into sort of producing that investment. And it's funny because when we watch movies about this stuff, sort of the BSL sort of for always exists, right? All right, we got this problem. Go into a lab, and it's downstairs and elevators and security guards and all that stuff. But when you start from scratch on something like that at a university sort of medical center, tell some interesting stories and any fun tidbits along the way of creating the SPU.
Yeah, I should say the SPU backs up the needle. So I'll talk about that in a
Right.
second. But the way that so I just finished, I did my fellowship, residency and fellowship in New York City, actually. I was at Mount Sinai as a resident chief resident, and then went to Columbia for my ID fellowship. And that was, as luck would have it, as circumstances often do for me, was during H1N1. So I was studying epidemic, pathogens with epidemic potential and health systems preparedness while responding to H1N1 as an infectious diseases fellow. And my ID project, infectious disease fellow project, was actually for healthcare worker safety during a pandemic, respiratory pathogen pandemic. And I very much knew at that point that the career that I wanted was a combination of both clinical care, infection control, but also more health systems preparedness
Mm-hmm.
around emerging pathogens. And the reason why emerging pathogens are so interesting to me in particular is that, and you'll see this thread throughout everything I've probably done, is that um, in general, infectious diseases, we need way more studies than we have in terms of the interventions. We recently have had some really great studies, right? The antibiotic durations and things like that. But emerging infectious diseases in particular are these new disease, you know, just presentations, these new
Right.
pathogens in many cases, where you're learning about the disease while you're responding to it. And it truly requires you to sort of take the current evidence and create consensus and make decisions iteratively to be able to improve the quality of care of the patients in front of you while you're increasing the scientific knowledge. To me, that's always been very fascinating. And also what's at stake, the stakes are big, particularly if the pathogen is going to, what COVID did. It had immense impact in terms of how we all lived in the last, 5 years or so. So when I finished fellowship, I actually wanted to move back to Boston because family's here, and my parents are still here. My father's has been in Harvard for a very long time. And so I wanted to move closer to family, and I emailed the head of the biosafety level 4 lab here, which is the National Emerging Infectious Diseases Lab, which had NEEDL, which is the BSL-4. And I said, are you looking for people who are working on the medical response side, right? If you have a occupational health, laboratory safety, because certainly I think they work on emerging infectious diseases. Biosafety level 4 pathogens are those for which there's high individual risk, potential, spillover and, potential public health risk. But they may or may not always be the most transmissible. It's just that they are very deadly, and we don't yet have medical countermeasures for them, right? So that's what separates them from like BSL-3, which is more like this is more for your audience. Like it's BSL-3s are sometimes it's the way that the studies are being done on pathogens. So tuberculosis can be BSL-3 in some cases if you're doing culture work, and sometimes it's not if you're working in an activated. So it's more respiratory. BSL-3 is more, many of the pathogens that are more respiratory are in that group. And funny enough, he was sitting next to when I sent that email, you open it up, Mark Klempner was sitting next to my fellowship director at a conference, and, worked out pretty well because most people don't get their jobs that way. You don't just randomly email a person and they're sitting next to the person who can vouch for you. So I started at BU about 2011, and my job was to create a medical backup program for the biosafety level 4 laboratory research program. In the unlikely event of an exposure or, God forbid, an infection from Ebola or Marburg or Lassa, right, in that space. And early part of my job was to actually just visit a lot of the other BSL-4s around the country to assess, there weren't as many. There was one document, I think in 2006, that was published by some of the other medical directors at that point of medical units. They were doing this, Rick Davey at NIH, Bruce Ribner at Emory, one of my close colleagues, George Reese, who was at St. Pat's, Missoula, was backing up Rocky Mountain Laboratories, BSL-4, who I ended up then actually volunteering in ETUs with a few years down the road. So they had written this paper, but there was we didn't have as much before the West African Ebola epidemic. This country didn't have as much experience dealing with viral hemorrhagic fevers. And so many of the units that were created were of like an older take on how you protect. It was built on the engineering, and the setup was built on BSL-4 laboratories. So the medical units that backed up the BSL-4 laboratories had similar sort of like, seamless surfaces. They had double HVAC, and backup electrical and all the things that you would never find in a hospital, right, in care of these patients. But what you might find in BSL-4 laboratories was copied into the medical units. So in addition to sort of looking at what others are doing, my job was to basically try to work with our city of Boston, and the state of Massachusetts, as well as the hospital and the university. The lab was on the university side, and the hospital is where the medical unit was going to be, to help identify a space, help design it with architecture, with engineers that came down from NIH to give experience, just thoughts on how we set this up. And then to recruit just a staff of medical workers across, nursing, emergency room physicians, ICU physicians, ID physicians, and to create protocols. And so for as you said, between probably 2012 at that point, 2012 to whenever it was that I stepped down. It must have been like a year or two into the COVID pandemic. The goal was to be ready in case there was a potential exposure or someone coming from the airport, right? Which is why we were state designated ETU physician Ebola treatment unit as well. And then so we had about a hundred, and we still have about 100 healthcare workers associated with that program that did regular training. We had medical protocols, clinical protocols for care, research protocols in terms of access to promising medical countermeasures for compassionate use or expanded access protocols being set up in the care of that work. And the other things that we did was we practiced with the BSL-4 lab, ensuring that the workers there knew what the procedures were for evacuation, for decontamination, for what to expect if the worst were to happen. Now, there hasn't been, thankfully, has not been a BSL-4 infection on U.S. soil, which is a testament to, I think, why it's a Swiss cheese model, right? It's the lab safety elements that are Swiss cheese, and then there's all the other aspects if something bad were to happen with an exposure. So that was it was really what to oftentimes when people think about the phenotype that people think about when they think about somebody who responds to pandemics are like virologists, and they'll think about like people who work more on basic and translational sciences. I think what you don't often hear about are probably people like me, but I do see that you interviewed Saira Madad, who probably has a similar phenotype to me, although I think slightly different focuses, right? Which is the people who work on response, they work on preparedness and response, they work on understanding the science on how pieces fit together with emergency management, medical care, and the science. It was so I did that for about a decade, and in between, for a couple of years leading up to my first deployment to West Africa and Sierra Leone during the West African Ebola epidemic. We'd been talking about going down, by we, I mean, a couple of us. It's a small community. The BSL-4 community is a very small community, and so we all know each other within that space. And a few of us who were on the medical side had talked about volunteering to help with Lassa fever cases that happen almost annually. To really learn from clinicians and physicians in Nigeria or other places that deal with it on a annual basis almost. And then the West African Ebola epidemic happened. And I remember it was the summer of 2014, and WHO put out a call for volunteers. And so George Reese, my counterpart at St. Pat's, Kate Hurley, who is the nurse at their unit, and myself deployed together in Kenema, Sierra Leone in 2014. And I remember hearing as I was well, I don't know if an hour is going to be enough for that experience.
No, let's just go.
This is we were hearing how bad the situation was on the ground, and I think that the crazy thing is that because my first departure aligned with the return of the first American who had been infected, Ken Brantley and Nancy Ridbull. Do you remember them? A long time ago. There was all of a sudden all this like media interest. And I remember I was somewhere in between all the stuff that I was describing. I was a hospital epidemiologist, associate hospital epidemiologist as well, because I can't ever do one job. I have to do 7. So I was doing that, and I was responding from that role in terms of our readiness here in the US for Ebola patients and care if there was a imported case. And the reporter asked me if I knew anybody who was volunteering or going down. I was like, well, actually, I'm heading down next week. And the next thing I know, there's like there's a news van outside my apartment, and they're contacting all these like folks at the hospital, and who is this person? And so I do an interview or two, and because the hospital's like, oh, this is great, we'll talk about all our resources and how we've been working on all these other amazing things that we've been doing here. But it kind of had this like almost like they were collecting B-roll in case I got infected, so they could play it down the road of like, look at this physician we interviewed, like we had the before role.
Right,
Um,
right.
so then I'm deployed, and I'm in Kenema, Sierra Leone, which was the epicenter in Sierra Leone, at least at that point, in August 2014. And I was there with other folks who were both American as well as those who were deployed from MSF, who were running a separate ETU physician in Kailahun, which is a little bit farther away from us. And then that their ETU shut down because there were a few healthcare worker infections there. And so there was a period of time in August 2014 when there was a new ETU that was supposed to open in Freetown, and the MSF end had been closed, and ours in Canada became really the only ETU that was open. And so there were, and just to tell you who was there, it was many of the local physicians had already been affected,
Okay.
unfortunately, or passed away from it, or had moved to the city with their families. And so there were 4 or 5 of us physicians, and there were about 8 or 9, national nurses, and many of the laboratorians. And the number of people, healthcare workers in that site in specific, since March of the year before that had been affected, was already like in the 30s, who had passed away.
Mm.
And actually, the last physician, a full-time physician, at that ETU died under my care. So it was horrendous, and we had about 120 patients in a space that was designed to take care of about 40 Lassa fever patients, that had been retrofitted, and the quality of care was abysmal. Right? I mean, there wasn't, because there was not enough resources, and the public health emergency hadn't really been declared. Um, and during my time there, 2 other people got infected. William Poole, Pooley, right? I'm trying to remember his name. Is a British nurse who got expatriated and went back to the UK. And then a couple of days after I left, Ian Crozier, who was my clinical lead, was also infected. You may remember Ian as he jokes as himself as the sickest Ebola patient that ever survived. So he was at Emory for a long period of time. And the rest of my year, that year was marked with periods of time where I'm actually, to this date, I'm really thankful to Boston University and Boston Medical Center, because I don't know that many other institutions had that kind of patience and the trust to be able to send their physician back
Yeah.
again and again, right, into the hot zone. So when I got back, I served as an instructor for the CDC, because they set up a course with FEMA in Anniston, Alabama, to train other healthcare workers who were going to West Africa. So I served as an instructor there, and then deployed again to West Africa in November of 2014 with Partners in Health.
Right.
Worked in E2s, served as their like head physician, and again was part of clinical care within the ETUs. And then left in November. Every time I got back, I spent 3 weeks in quarantine, because if you remember, that's what happened if you were
Yeah.
returning from the Ebola response. You spent weeks and weeks in quarantine. Went back again in February, January, February, and then went back again in June. And the latter half of those visits were transitioning to probably some of the more health systems transition stuff of how we take some of the lessons learned and the resources in a period of time where the epidemic was coming to an end, but there was an uncertainty, because now if you're in the middle of an epidemic, you can keep your vigilance up. But when you're at the end of an epidemic, how do you ensure we continue that vigilance in case that sporadic case comes in with
Right.
Ebola? But yeah, that's I could go on forever, but that was my West African Ebola epidemic. And because of that, it led to further work in Liberia, as we talked about, as well as what I did later in my life, which was I served as the clinical lead of a viral hemorrhagic clinical research unit, which provided higher standard care in Uganda, in Fort Portal, which is at the border of DRC. So I actually worked in Uganda, not DRC, but it was at the border of DRC. So we responded to outbreaks in DRC through cross-border readiness.
Mm-hmm. Mm-hmm. No, it's an amazing a set of work, and it just I guess and I promise you we will get to the seed in a little bit, but there's just a couple other themes that I want to bring together there from what you were doing, say, in Sierra Leone, because I know you published with this group in the Journal of Infectious
Partners in
Diseases.
Health.
Yeah, and with your Partners in Health, 2016 October, it was it's on strengthening health systems while responding to a health crisis and the lessons that you learned, specifically in the Ebola epidemic in Sierra Leone. Um, say a couple words about that if you would. Obviously, we think about, okay, here's the response, but and we hear this all the time, right? We need to strengthen these health systems, or else we can have as many antibodies and vaccines as we need, but the core system we need to properly build up, whether that's Sierra Leone or here. And then if you could also just take us a little into your White House work, because there, you're involved in a couple different, you're involved in COVID response on one hand, but then also, this theme of I'll put it in the sort of the global health diplomacy basket, vaccine sharing.
Yeah.
There's many pieces to this puzzle, and I'd love for you, again, we'll get to the seed after this, but I'd love you to talk a little bit about this, because I think this gets overlooked a lot. And I forget who it was, actually. So we just tend to forget. We have this amnesia. Okay, we dealt with this Ebola thing and we didn't forget everything, but no, there's other things that we got to do, so Ebola 2 doesn't happen. And I'm wondering if you could talk a little bit about some of your experiences that in terms of strengthening health systems, but also the importance of sort of this global health diplomacy piece within that.
Yeah, so I'll draw an arc from that paper that you mentioned, the Partners in Health and the experience in Sierra Leone, to some of the work in Uganda, and then to the White House. And I think, they're all connected. I think that paper makes a pretty obvious case of like the baseline health systems help us determine how quickly we figure out when there's an outbreak, because it means how quickly can people come to care, how quickly do they get diagnosed, how quickly is that reported up. But then it also determines, a lot of times you hear about all these deadly diseases. I often say this to my students about this idea of, like, a lot of times deadly diseases are deadly partly because of the way that they present in a particular health system. So you can talk about Marburg, right? Marburg, there's a whole range of like mortalities, like 30 to 70%. And the reason why the traditional mortalities are so high is because it depends on the health system that you present it in. So Rwanda just faced a Marburg outbreak last fall, as you might remember, and their, mortality was like half of what was been reported. Partly because their baseline healthcare systems are much better. They have better access to, quicker access to care if a patient gets sick, better supportive care, organ support, more healthcare workers. In Sierra Leone, they had, like, I would say, if I remember correctly, I think it's less than 2 physicians for 100,000 or something, if that. And so the care, and maybe a few more nurses, and community health workers, but the care you provide determines the deadliness of a disease. And
Okay.
again, I think to that point of, like, people tend to think about just the biology, and even when we think about response, we just think about vaccines, therapeutics, and which are all needed, diagnostics, all needed. What we don't think about is that it's about whether people can get access to that, and that you can't just assume those things will happen. You have to prepare for that. You have to have station for that. And people tend to hand wave. Oh, physicians will do that.
All
That's
right.
not what happens. Healthcare systems need to be set up, and it's just, patients need to have trust in the systems, and they need to want to come to care and know that they will get good care and it will make a difference. Um, and I lost, I don't know, nearly 50% of my patients in Sierra Leone, particularly in the worst weeks of during my time there, because it is a deadly disease. And part of what makes it deadly is that you have this massive fluid loss, and even simple things like IV fluids, right? If you have if you have 100 patients and there's only 4 healthcare workers in the unit, how many people are you going to be able to give massive amounts of fluid resuscitation to? So I think that's partly what, when you look at that experience with work that we did in West Africa, in Uganda with something called JMEDICC, Joint Medical, I always get it wrong. Infectious diseases response capability or something. It's a DoD-funded program in partnership with Macquarie University and the Ministry of Health. And it was a 6-bed unit that was what it did was it improved the standard of care, the supportive standard of care. Because if you have a treatment, let's say you have a treatment for Ebola, you don't know how well it works if the standard of care itself is pretty low, right? And so is it the drug that's working, or is it because you are doing better supportive care? So if you could control the standard of care and improve the standard of care, then you have a better sense of whether the drug works or not. So in that unit, we did work on, again, healthcare worker training, infection control, access to experimental protocols, expanded access protocols. And the reason I'm drawing this out is because many years later, when I was at the White House, I'd already left JMEDICC as a clinical lead because I'd taken this government position. I'd been at BU this whole time, but I was seconded, to some of these other things. While I was at the White House, I was in these meetings about the response in Uganda with the Sudan virus, the Ebola virus, the Ebola Sudan virus outbreak that happened in Uganda in 2022, 2021. So I'm hearing this, and Ira, the unit that was the center of excellence, the one that took care of healthcare workers, that was part of that response, was the JMEDICC unit, which is what we'd been working on, right? So your point about why health systems matter, that investment of years in that unit by Uganda, by healthcare workers there, by all of us, actually ended up being what improved the Sudan virus response in Uganda years later. So when for the White House position, so I had just founded CEID in 2021. And a year later, I got a phone call from Ashish Jha, who I had gotten to know,
Sure.
who's the COVID coordinator for the White House. And he said, I'd love for you to come and work with us on the global COVID response side. And I was a little worried because the university had already made this big investment in CEID, which we're going to talk about in a second, leaving that a year in, right, to join the White House. But in the end, I ended up taking a sabbatical from BU, moving to DC, and and joined the federal government for that year, which was focused on global COVID response. And it was coordinating our activities across different agencies, as you mentioned, for COVID-19 vaccine donations. And so the U.S. has donated, was the single largest nation state donation amount in the world. So we donated nearly 700 million COVID-19 vaccines. And in my time there, it was later in the pandemic, but I think it was like 300 million during my 1 year that I was there that we were able to get out, which is incredible when you think about it, right? When the thing that my White House experience taught me was just the incredible scale of working in government and the impact that has, potentially to affect good in the world.
Yep.
So you don't, when you're a physician, you talk about hundreds of patients or thousands of patients over the course of your career. When you're a public health person, maybe you've been lucky enough and you've affected hundreds of thousands or 1 million. When you're in government, you're literally touching billions of lives, and it's an incredible responsibility, So during that period of time, some of the other things that I did were working with our National Security Council to think about how we transition our investments in COVID-19 on the global front to transition them into health systems preparedness. And, there's work there in terms of how we all this investment in diagnostics globally in COVID-19, how could they be transitioned to help with the potential future, right, epidemic? How do we use the COVID-19 vaccine work that had been done globally with the ACT-A accelerator? So we worked in partnership. Huge part of the US's work is in partnership with WHO and COVAX, which is the utility that was helped set up by the international community to donate. But we also did a lot of bilateral donations. So it was trying to figure out how we, as the interest in COVID-19 vaccines were going down, right? We were towards the period of time where there was many countries already had vaccines, how you use that experience to build better adult routine immunization plans globally. Because that has implications for future pandemics as well. I mean, H5N1, right? Like that's not. The other two things, as you mentioned, that I did there, early in my time in that position, the Mpox, pandemic also occurred. And so I served until there was a more permanent person, I sort of like also served as an interim testing coordinator, helping us think through how we expand our Mpox testing capacity, through regulatory approval with, thinking through with CDC, and FDA, thinking about like how we get that to the right places in the country to improve our uptake, testing turnaround time and uptake for testing. And then the latter half of my time there, I was the White House contact, the White House liaison, and policy lead for, as you mentioned, Project NextGen, which was a $6 billion, which was a $6 million sort of program that the White House COVID response team was working with HHS on, helping think through how we get to vaccines that are not just chasing every variant, but they could affect, more broadly covered COVID, not just COVID, but COVID-19, but like beta coronaviruses, which are a pandemic. We've got SARS-CoV-1, we've got MERS, we've got COVID-19, SARS-CoV-2. They're all part of this beta coronavirus family. And so how do we invest in science, right? I mean, at the White House, this is the other thing that you sort of like was a big lesson for me, is that what you're doing is in the policy world, your impact in the world is not the direct impact of like, oh, I just saved a patient in the NICU, right? It is what levers do I pull now that years down the road, it's going to have an impact. So it's a different type of way of thinking of how do you affect change. The theory of change is very different. So that's partly what I worked on. And then in the aftermath of that, I returned back to BU, which is where I'm currently.
Awesome. And that's, a perfect segue into BU, Center on Emerging Infectious Diseases, also the CEID core mission for their website to improve resilience against the threat of emerging and epidemic infectious disease worldwide through public health and policy research, global and local capacity strengthening, training, evidence generation for policy support, and community engagement. We'll obviously put a link to the CEID in the bio of the show, because I have to say there's lots of stuff going on at the CEID. That being said, I thought we could drill down just because we don't have 10 hours, but we could record for 10 hours, but maybe on some of the research cores that you've set up there, because each one on its own extremely important in this story. And I thought an interesting place to start off would just be on the data science and surveillance core. You wrote a quite interesting paper just 2 months ago in November in JAMA, entitled "An Improved Alert System for Emerging Infectious Diseases." And here, you propose, look, we have infectious disease outbreaks, and not just yes or no. Hey, we got Ebola, we don't have Ebola, but there's a lot of gray in between. And you interestingly propose this very interesting system, sort of similar to the DEFCON system for nuclear war, and sort of supporting that different projects like Epistorm, which is a CDC thing for in sort of advanced modeling, systems to predict when an epidemic becomes a pandemic, and so forth. I'm handing you the floor back on this one. Take us through a little bit of what's happening in the data science and surveillance core, because it's all extremely important in 2025.
Yeah. Well, the interesting thing for me about becoming a center director is that center directors, like all of a sudden, when you're an individual faculty, it's about your research and your papers and moving forward your career. When you become a center director, it's so much fun when you sort of like get to sit back and say, what are the important questions and how do I support everybody else to also be able to answer those? And so the four cores that you mentioned, the data science and surveillance, the climate change and One Health, the public health, trust and communications, and the medical and public health response cores, were all they all came together because we have a core faculty of like around 35. I think it's growing every semester a little bit. So it came about from what the expertise is within our center. Which pulls from almost 9 schools and colleges and departments within Boston University, and it's truly multidisciplinary because we've got folks from engineering, from law school, from school of public health, from medical school, of course, but also College of Communications, right, and social work. And so seed was the importance of seed is that you can't just have a biologically focused response to pandemics. We want to make it all about, as we talked about at the very beginning of this conversation, vaccines, diagnostics, and treatments, which are important. We have to think about pandemics in the way that they affect us, which is they affect us in every aspect of our lives. And you can see the COVID-19 experience kind of manifests that, which is you can have vaccines, but you'll need people to take the vaccines and
Right.
you'll need people to have trust in government to be able to sort of impact change. So the data science and surveillance core is run by Dr. Laura White and Dr. Kayoko Shiota. Laura is a statistician that works in disease modeling, and Kayoko is a veterinarian who was previously with the CDC, and again is a epidemiologist and statistician. Um, they're part of the Center of Excellence called Epistorm, which is a funded center by the CDC Center for Forecasting Analytics, Forecasting and Outbreak Analytics. And it looks to evaluate and when you don't have enough data in an ongoing outbreak, how do you make best prediction models in terms of with the data that's available, and to work on new statistical methodology to be able to answer questions in the middle of emergencies. Um, in that core, they also have a lot of work on things like how do Kyoko's interest, one of her interests is like post-vaccine approval, effectiveness studies, in the public space. And so what data sources to use. So that's one aspect of it. Another project that I kind of want to talk about that falls in that general, umbrella at SEED, which is what I'm leading. I'm the director of something you mentioned earlier, which is the Biothreats Emergence Analytics and Communications Network Beacon. So people may be familiar with ProMed or Health Map, some of these other sort of more web-based informal surveillance systems. So what Beacon does is it sort of takes this concept of informal surveillance systems, the idea that if you pick up a signal, a chatter about an outbreak, a biological event, and if you can verify it and report it, the experience for some of the other folks who've been doing this is that a lot of times it ends up being before the formal reporting of the outbreak. And what it does, it raises awareness of the outbreak and mobilizes the global community. So Health Map was one of the first to identify. Same with ProMed, identify the COVID-19 cluster in December of 2019. Even before, right? It was one of the posts. So the idea of getting the message out. So what Beacon does is combines the best of that, which is human verification, a globally based network of subject matter experts, which is what we have, and a AI LLM based power engine, which basically takes the signals, evaluates them for severities, presents it to the human moderator to be able to say, is this accurate in terms of severity of what might happen with this signal? And then it creates a context that can be edited by the human, then posted. So think of it as like outbreak Twitter, which is, which we we have reports for each of the biological events that are going on. And so that's going to launch in April of 2025. And we're very excited. We have on our interim advisory group, we have Dylan George, who's the head of the CDC Center for Forecasting Analytics. We have Sir Jeremy Farrar as an observer, who's the chief scientist of the WHO, as well as representation from Gates Foundation and elsewhere. So we're very excited to bring that to the world because it's going to be free. It's open source. I've always felt that like if you can't have surveillance and detection and reporting that is completely open source, that you can't move the needle in terms of getting a global engagement and response.
Excellent. CEID has a One Health climate change core, and this has been an extremely important topic for us over the last couple of years, obviously. And we've discussed all sorts of scenarios on when you mess with Mother Nature and ecology, and the bats have no place to go, and they go the wrong place, or the baboon jumps on the cow, which the farmer works with, and so forth. So obviously, the One Health extremely important. Would love to just to go into a little sort of some of the some of the important targets there, and then as a side piece of that, and I just as people watch the show know, I love going to our guests' literature and picking out some of the oddballs that are in there. But this one, because it's kind of connected to One Health, and I'd love for you to say a couple words on it. This was a few years ago. You wrote a paper in 2015 on the infections associated with eating exotic cuisine, and I never really thought about that. I don't eat that exotic. I mean, I eat sushi, but but some of the stuff in this paper, which I've never, I've said these words for the first time when I was reading it, things like anisakaidosis and gnatostomatitis and sparagnose. What are these things, and and what should we not be eating? Obviously, I probably shouldn't be eating turtles and snakes and so forth, but love to hear sort of One Health issues associated with eating stranger things than we normally eat.
Yeah, well, we as humans have been eating stranger things our entire lives.
Right.
And I think that if you read through that entire paper, just at the end you come out, you're like, most of the world, most of the world's cuisine, most of the world's like delicacies, even the exotic ones, if you cook it well enough, it's fine. A lot of times the issue has been like many of the things that we talked about in that paper, I think, is delicacies that may not be cooked through or may have stranger infections that we don't have as much immune experience with. So One Health is, I think it's close to my heart. I consider myself, I consider climate change for me personally as one of the biggest issues that I'm concerned about. Actually, I know people will be surprised to hear this. I worry about climate change even more than a next pandemic. Because it's already affecting us. You can see the stuff that's happening in terms of the last few years. The U.S. has seen more 20 billion or more worth climate-related disasters than any other. We've all seen how it's impacted our insurances for home and all that other stuff. Everybody's seen their home insurance go up, and it's partly because of the weather patterns, the weather-related the travesties that have happened. But the way that that's affecting so One Health and Climate Change is led by Dr. David Hamer, who's helped co-found GeoSentinel, which is a program which is around for like a long time, looking at returning travelers and potentially tracing outbreaks to their source from returning travelers, as well as Kayoko Shiota, who's a vet, as I mentioned. And their focus is they're looking at multiple things. One of them is vector-borne diseases, or a push virus like that's happening right now, or some of the things we talk about with mosquito-borne viruses that are expanding their risk here in the Northeast, Triple E, West Nile, which is seen spread everywhere, most of the states in the U.S., and then also considering how climate change affects delivery of care, right? Availability, supply chains, use of antibiotics, etc. So it's their core, which includes others within it, takes multi sort of disciplinary approach, looking at everything from vector biology to more health systems approach and the impact of climate change on that. David is if you ever want another guest, David is a wonderful guest who can just tell you about the 15 years of work that they've done in terms of some of the, the climate change issues related to, the changes in pattern that they've seen in returning travelers or in sort of the disease surveillance that they've done in that period of time. I think we are in almost everybody that I know that's in this field talks about, the climate change has impacted the distribution, the risk, right? The magnitude of infectious diseases that we already know, and they're potentially the way that we're using the land around us, and the way we're interacting with nature. Climate change is increasing the chances of emergence of new infections. And that's really at the core of the type of work that we're trying to do, is understand those two dynamics.
Excellent. Excellent. Yeah, we gotta tell some of these people in my Instagram feed to stop eating all that stuff that they're eating raw, but that's another topic. Trust in public health communication, very, very important research core. And it just happened that 2 days ago, I'm joined on the show by Marcia McNutt, president of the National Academy of Sciences, and she's giving a presentation at BU. This was a couple of years ago, on this term in the Oxford Dictionary that was put there, I think, a couple of years before. It's called post-truth. And, she gave this really interesting talk about how bizarre it is that we are in an era where feelings and intuition somehow became more value over scientific expertise, how scientists are seen as special interest groups. Kind of wacky for 2025. Very important piece of this core for you: building trust in science, proper public health communication, respect for our public health institutions. As important to this as, preventing the next Ebola outbreak. Talk a little bit of what's happening in the trust in public health communication core.
Yeah, so led by Professor Tracy Hong at the College of Communications, and was up until last year co-led by Professor Veronica Wirtz. And actually, Veronica did a really nice. If anybody just wants to get a primer on trust in the literature that's out there in terms of building trust in better public health communications, we do have on the CEID website the bibliography that she put together about, particularly coming out of the COVID-19 experience, what studies have shown in terms of best approaches. So I encourage people highly to go to that and find it. It's been useful for me. I mean, it's not my field, right? I'm more on infection control, medical care, and health system stuff. And then Tracy also does a lot of work on big data analysis. For example, they had a couple of studies looking at how religious messaging was used to affect in increased misinformation and distrust in vaccines among pregnant women in 3 major middle-income countries around the world. So how messaging works. Tracy's work is around, looking at public sentiment and looking at ways that changes over time and what interventions would be successful in that space. But there is some really great, exciting work coming out of their core with some of our new faculty members who are working on public engagement, community engagement, and looking at how we do that more effectively. I know we're running out of time, but I could talk forever about why I feel like that's so important and critical as well.
Yeah, no, it's extremely important. And yeah, I realize we're up against the top of the hour. While we have you, if we could just hop into the future for maybe a minute. 2 very important pieces that you published, one in Journal Biomedical Informatics and one in the International Journal of Medical Informatics, 2024 September, on how you see systems like artificial intelligence systems like ChatGPT automating certain parts of sort of the biomedical literature review, to ultimately give us insights to whether it's for disease detection, whether it's for novel countermeasure development for these emerging zoonotic infections. I'd love to get your sort of,
Yeah.
looking over the horizon with some of these novel AI tools. Obviously, AI is hot. Where do you see some of this going in terms of the CEID mission?
Yeah, and actually, that's some of that work that fed into Beacon, right? Because Beacon is
Right.
also in part like it's driven by a pandemic LLM. So this is both of those papers. I was not the primary. I was a co-investigator, but it was led by Yanis Pascalidis, who is a professor of computer engineering at the Hariri Institute. And Hariri Institute for Computing and Data Science is actually one of the major partners for us at CEID because of what you said. I think AI is up and coming, and we're seeing all these great use cases for AI. I think the tough lesson for me throughout this entire period of time is that generative AI is actually still pretty rare. So you have to learn the limits of large language models, what they can do, and what they
Right.
can do is actually still quite powerful. But you need to have the right use cases, and you need to sort of have all the caveats in place. And the two papers that you talked about there, one was how, based on PubMed and other sort of reference databases, how we can program a large language model to look for drug epitopes for drug
Yep.
drugability, that we can identify if there's a new pathogen from a known family of priority pathogens, that we can quickly have this LLM look through and save time for researchers who are thinking about developing potential therapeutics and vaccines. The other paper is picking up signal from the noise from EMR, from electronic medical records during, flu seasons, winter seasons, respiratory seasons, to say if it can we predict if something above the normal seasonal variability is going on. And that was also actually pretty it was exciting that it was able to sort of pick up, for example, and predict what would have happened with COVID had it existed back then as well.
Awesome. Awesome. An amazing set of work. I mean, I could go on for a couple of hours talking with you, and we should definitely do a follow-up episode to get into some of the things we didn't today, but just really very impressive. I wish you and the team, as you continue with all these programs, the best with it. Again, for everybody that's going to be listening to this episode across the podcast networks or watching on the YouTube channel, again, you've been spending time with Dr. Naheed Bhadelia, founding director, Boston University Center for Emerging Infectious Diseases, associate professor, BU School of Medicine, doing really amazing things to improve resilience against the threat of emerging and epidemic infectious diseases worldwide. Naheed, I really want to thank you again for taking the time out of your schedule. Thank you for everything you do there at the CEID. And as we like to say on our show, thanks again for helping to create a better tomorrow for so many people and a safer tomorrow for all of us.
And thank you for having me, Ira, and thank you for everything you do to try to bring these messages to the public.
Great having you.